from the Virginia Department of Health. Good afternoon and welcome to the group meeting for Chapter 932 of the 2020 Acts of General Assembly. This meeting is being conducted in a completely virtual environment and is being recorded. There are several things that we'd like to review before getting started. First of all, if you're not speaking, would you please mute your microphones? We ask that members of the work group mute their lines if they are not speaking, as this reduces the amount of background noise. We also ask that due to the virtual nature of the meeting, would you please identify yourself each time you begin to speak so that staff can accurately record the minutes of this meeting. For those attendees who are not members of the work group, you will not be able to unmute yourselves, but when we get to the public comment period, you will be unmuted by the host if you have signed up to speak. We have an outside speaker presentation to the work group today. He has been given 20 minutes to speak with 10 minutes afterwards for questions and answers. We ask that all comments and questions directed to the speakers be specific, constructive, and aimed at their presentation. Ms. Allen, please call the roll.
Alyssa Black-Hackett, are you on the call? Megan Green, are you on the call? Judy Jackson had emailed saying that she was going to be a few minutes late, but I'm going to check and see if she is maybe in our attendees list. So 1 second, please. Judy Jackson, are you on the call on the attendees list right now? Okay. She'll be joining us later, I suppose. Karen Brim, are you on the call?
Yes, I'm here.
All right. Joni Latimer, are you on the call? Gail Thompson, are you on the call? Jewel Brana, are you on the call? Catherine Paxton, are you on the call? Charlotte Redoubt, are you on the call?
Yes.
Elizabeth Carter, are you on the call?
Yes.
Corey Tillman Wolf, are you on the call?
Yes, I'm here.
Kurt Elward, are you on the call? Barbara Seymour let me know that she was not going to be able to attend today, but she has sent someone in her place. Terry Smith, are you on the call? Terry Smith, are you on the call? Randall Stamper, are you on the call? Todd Barnes, are you on the call? I'm sorry, did I hear someone say yes?
Yes.
All right, thank you. Heather Legary, are you on the call?
She is on the call. This is Todd. She's in another room, but she is on the call.
All right, thank you. Sam Kukich, are you on the call?
Yes. Yes.
Okay, I think you're okay. Yes, you're in our attendees list. If you'll just give me a second, I'm going to bump you up to panelist. Just 1 moment. Okay, and then I just got a message from Mr. Stamper saying he's on the call. Mr. Stamper, I'm going to manually unmute your line. Can you test your audio now?
Can you hear me?
Yes, Mr. Stamper.
Okay, thank you.
All right, Bob Kukich, are you on the call? Aaron Hines, are you on the call? I'm sorry, was that a yes?
Yes.
Okay, you are also in our attendees list, so just one second. I'm going to upgrade your privileges to your panelist. Susan Hines, are you on the call?
Yes.
Okay, I think there's actually two of you in our attendees list, so let me make sure I've got the right audio for you. Okay, I've made you a panelist. All right. Lionel DeCoeur, are you on the call? Can you hear me, sir?
He's on the call, but he may be muted.
Okay.
Yes.
I've manually. Okay, I hear you, sir. Thank you. Senator Kiggins, are you on the call?
Yes, I am.
All right, thank you. Christina Holloway, are you on the call? Dana Parsons, are you on the call?
This is Melissa Andrews. Dana's going to be late to the call.
All right, thank you, Melissa.
Sure.
Alicia Cundiff, are you on the call?
Yes, I'm here.
April Payne, are you on the call?
I'm here.
Scott Johnson, are you on the call?
I'm here, thank you.
All right. Vivian McDaniel, are you on the call?
I'm here. Thank you.
Joseph Hilbert, are you on the call? Heather Anderson, are you on the call?
I'm here.
Dr. Pratt is here, and I think I saw Joni Latimer join the call. Are you on the call, Ms. Latimer?
On the call, thank you.
All right, thank you. And then just one last check. Has Judy Jackson joined the call? Okay, she's not joined the call yet. Dr. Pratt, I know you're on the call, as am I. So that concludes the roll call.
And could you change the screen to show the agenda?
There we go. Okay, so am I still unmuted? Yes, okay. So the agenda for today's meeting is on the screen. We will begin with a public comment period. And if you'll give me a second, there's some reverb. I'm going to mute. Okay, I think that should have taken care of it. Hello? So the agenda is on the screen for today. We're going to begin with our public comment period, followed by a presentation by Brendan Rivenbark on nursing home staffing and supporting the development of Virginia's nursing home workforce. We're going to review recommendations that we have discussed to date in our prior meetings, which will expand into a recommendations discussion, followed by discussion of next steps and any other additional business.
Thank you. This brings us to the public comment period in today's agenda, and I'll review for you how this will work. When registering for this meeting, there was the opportunity to sign up to speak on a topic. The list of persons who signed up to speak was finalized at 11:30 a.m. this morning. Pursuant to the Board of Health Public Participation Policy, each speaker will have 2 minutes in which to speak. There will be a countdown timer on the screen, and a bell will sound when the time has elapsed. If the bell rings while a person is speaking, that speaker will finish the sentence, and then the speaker will be muted, and the name of the next speaker will be called. You'll be unmuted by the host when it's your turn to speak. In addition, all speakers are reminded that this is an opportunity for you to address the board on any topic of your choosing. However, it's not a question and answer period, and there will not be any dialogue back and forth between speakers and workgroup members. If we have more speakers than the time allotted now, the remainder of the speakers will be permitted to speak at the end of the meeting under the same rules outlined for this public comment period. Ms. Allen?
Okay. As of 11:30 a.m. this morning, there were 3 individuals who were signed up to speak. The first person who was signed up to speak is Susan Hines, and then on deck is Ms. Sam Kukich. Ms. Hines, if you'll just give me a second, I'm going to throw the timer up on the screen, so just 1 second. Okay. Whenever you're ready, Ms. Hines. Ms. Susan Hines, to be specific. Ms. Hines, I am not hearing anything, so just hang on a second. I'm going to manually unmute your line for you. All right. Your line's unmuted.
Thank you. Okay.
All right, whenever you're ready.
Are you getting a lot of reverb?
I am. If you could do me a favor, could you, on your computer or whatever device you're using to watch or listen to this, can you turn down the speaker so it's not picking up your voice twice?
Okay, is that better?
It's a little bit better, but not not by much. But if this is the best we can do, then that's the best we can do. All right?
Can you come back to me and I'll try something else?
Sure, that sounds fine. With that being the case, then Ms. Kukich would be next, followed by Ms. Erin Hines, and then we'll circle back to you, Ms. Susan Hines. All right, are you ready, Ms. Kukich?
Yes, I am.
All right, whenever you're ready.
Allow me to give you some facts to ponder. Virginia ranks 36 out of 50 states in the provision of health care for residents in nursing homes. 100 of 250 nursing homes in the Commonwealth provide less than 2 hours of daily care per resident. Instead of tackling the problem at hand, this work group continues to listen to agencies seeking funds to put more healthcare workers in the pipeline. Why have we not asked CNAs why they are leaving? Read some of the comments from citizens who have taken time to write. They are very specific and speak from experience. Putting more people in the pipeline so that they too will be overworked, underpaid, and working long hours resolves no problem. To my mind, this work group has accomplished little to date, save protecting the patients of those who are truly interested in resolving this problem. The private equity firms will continue to make huge profits. The politicians will continue to protect them to stay in office. Owners will continue to use nursing homes as a front to feed the greed machine, and the CNAs will continue to be used as slave labor and set up for failure while the elderly die. Why is there such a lack of respect and discrimination against the people who fill these CNA jobs? They are apt to be less educated, in many cases a minority. They're the backbone of nursing homes, and they come into the field with hearts of gold only to realize that they're being set up for failure, paid poorly, disrespected, and we wonder why there are shortages of CNAs. In conclusion, the dictionary defines a coup de grace as a final blow or shot given to kill a wounded person or animal. It's an action or event that serves the culmination of bad or deteriorating situations. The coup de grace for those elderly spending their final years in poorly staffed and poorly managed Virginia nursing homes is the manner in which this work group has gone about its mission. I beseech you as members of this work group to find the courage to address the real problem before us.
All right, thank you, Ms. Kukich. Ms. Erin Hines, you are up next, followed by Ms. Susan Hines. Are you ready, Ms. Erin Hines?
Yes, I'm here.
All right, whenever you're ready.
Okay, I'm ready. My name is Erin Hines. I am with Dignity for the Aged and also work as a CNA. CNAs, do you ever feel like you are a failure? Sadly, I've seen this question way too many times on a CNA Facebook page lately, and the responses poured in. We work extremely hard caring for our elderly, and it is very important and rewarding work. But why are so many of us feeling like failures? Please listen to their answers and their responses to this question. Our CNAs are drowning and need our help. I feel like a failure all the time because I feel like I'm failing my residents when we are so short-staffed. Yes, the demands of the job can be really high on certain days, too much for one person, and when I can't do it all, I feel like a failure. Not a failure, but very underappreciated. Yeah, sometimes I do. I really feel like a failure if I don't get a few extra minutes to sit and chat with my residents. I know how much they need that. Not so much a failure, but severely overwhelmed. All the time. I feel like my best is never good enough for anyone. I feel like me and most of the other CNAs keep the place floating. The management is what's failing. I feel that the system sets CNAs up for failure, and you feel defeated before you even walk in the door. I have to constantly remind myself that there's only so much one person can do. No, but the job makes me feel like a slave. All the time, no matter how hard you try, it seems like it's never enough. These are some of their many comments. Please take them to heart. Like I said at our last meeting, 75% of CNAs that answered my recent survey said that they have never been asked by anyone what they could do to make their job easier or better. Our CNAs are greatly needed. If we don't want them to quit, we better fix this problem.
All right. Thank you, Ms. Hines. Ms. Susan Hines, are you still with us? Ms. Hines,
Yes.
are you there? Ms. Susan Hines?
Yes.
Okay. All right. There's a slight reverb, but it sounds better than it did previously. So whenever you're ready.
Okay. So as I said in my comments from our last meeting, approximately 380,000 of our nursing home residents in the United States die annually from infections. Infections are due to lack of quality care, and the lack of quality care is directly related to understaffing. This doesn't even account for the fall deaths that have increased 30% over the years 2007 to 2016. And the United States federal government has mandated a law in 2010 that gives our elderly these rights: freedom from abuse, the right to be treated with dignity, the right to visitors, the right to have necessary care and services for highest practicable well-being, and the right to have adequate personnel. So I am asking, are we providing quality care if we are losing that many residents due to infection? I think the answer is a resounding no. Erin Hines did a survey on the CNA Facebook page, which asked if you were going to leave your job as a CNA, what would be your top reason for leaving? The number one reason was low wages. The number two reason was burnout and understaffing. The only way Virginia can provide quality care is to mandate ratios. North Dakota is doing this, and they score high in every survey. This is our watch. It is our responsibility to do something about this. We need to act for those who cannot act for themselves. Shame on us if we do nothing again.
All right. Thank you, Ms. Hines, and thank you to all of our speakers who offered public comment. Dr. Pratt, this concludes the list of individuals who had signed up to speak by 11:30 a.m. this morning, and the public comment period of today's work group meeting is now closed. And if you'll just give me a second, I will shift everything back over to the PowerPoint presentation.
Thank you. We now have a presentation about nursing home staffing from Brendan Rivenbark, who is with the Virginia Department of Health Office of Governmental and Regulatory Affairs. Mr. Rivenbark.
Good afternoon. Before I get started, can I just do a quick sound check? Can you hear me okay?
Fine, yes, thank you.
Great. Well, good afternoon. My name is Brendan Rivenbark. I'm a senior policy analyst in the BDH Office of the Commissioner. I want to thank Rebecca and Dr. Pratt for allowing me to present to this work group on the topic of nursing home staffing and opportunities to support the development of Virginia's nursing home workforce. I see a lot of familiar faces in the chat box. I'm happy to be with you all today. So during today's discussion, I'm hopeful that we can leave a lot of time for question and answers and discussion. We're going to revisit the background and charge of this working group, review staffing requirements in Virginia and nationwide, explore data between states, and discuss opportunities and recommendations.
If you're not speaking, use your microphone.
So as a reminder, this working group is charged with developing recommendations to increase the availability of the clinical workforce for Virginia's nursing homes, whose historical staffing challenges, as with other states, are complex and multifaceted, requiring braided approaches and strategies to address. In the context of staffing data, ratios are often defined as hours per resident days or staff to resident ratios. Our reason for reviewing these ratios is to initiate discussions on developing goals for Virginia's nursing home staffing workforce. So as this group is well aware, nursing home staff, including licensed nurses, CNAs, and other personal care aides, are critical to the physical, mental, behavioral, and social well-being of nursing home residents. Numerous studies have found positive relationships between nursing home quality and staffing quality, yet many nursing homes have lower than sufficient nursing home staffing levels, which exacerbates our current staffing shortages. Virginia's nursing homes, as you all are aware, are required to provide qualified nurses and certified nurse aides on all shifts 7 days per week in sufficient number to meet the assessed nursing needs of all residents, although sufficient is not defined any further. In addition, Virginia's nursing homes that participate in Medicare and Medicaid programs are required to have a full-time director of nursing, a registered nurse on duty for 8 consecutive hours, 7 days a week, and one registered nurse and an RN or LPN for 2 additional shifts. While all nursing homes that participate in Medicare and Medicaid programs are required to adhere to the staffing standards set forth by CMS, many states have imposed more defined staffing requirements. A few examples of these nursing and direct care requirements are listed on this slide, and this is not, I know there are other states that do this, and this is not intended to be inclusive. This is just a quick screenshot of what other states are doing. So, for example, California requires at least 3.5 hours per resident day, with at least 2.4 of those hours provided by a CNA. Illinois requires at least 3.8 hours per resident requiring skilled care and 2.5 for residents requiring intermediate care, with at least a quarter of those hours being required to be provided by a licensed nurse and the remainder may be provided by any personal care provider. Main requirements leverage the staff per resident approach, with 1 direct care provider for every 5 residents during the day shift, 1 for every 10 residents during the evening shift, and 1 for every 15 during the night shift. Washington, D.C. requires a minimum daily average of 3.5 hours per resident day to be provided by an RN, LPN, and or CNA. Florida requires 3.6 hours per resident day provided by CNAs and licensed nursing staff, with at least 2.5 of those hours to be provided by a CNA. And they also require a CNA ratio of 1 to 20 residents, and for licensed nurses, 1 to 40. This slide presents comparison data on a few relevant measures, including hours per resident day of licensed nurses and CNAs as reported to CMS, the number of hospitalizations per 1,000 long-stay resident days, which is a key CMS quality indicator. We have also compiled data highlighting the CNA hourly minimum wage, total CNA workforce, CNA jobs per 1,000 jobs, and the Medicaid spend per enrolled aged individual 65 and older. Please advise, this data is not intended to be presented as causal, nor are all the data from the same time periods due to data time loss. Rather, this data is intended to initiate discussion and highlight the complex relationship between cost, quality, and access in our nursing homes. Also, these data are in no way intended to imply that there is no workforce shortage in Virginia, and we understand how regional differences across the state may skew this data. A few initial observations of interest to this team are, currently, Virginia's hours as reported to CMS on hours per patient day are fairly close to what other states have mandated as minimum. And again, that's not to imply that our staffing ratios are adequate. It's more so that there's regional differences that are skewing that data, but we do have data that say that we are providing similar data to what other states have mandated. And higher costs do not necessarily translate to higher wages, which are not necessarily indicative of higher quality for our nursing home residents. A key example of that, if you look at some of the blocks that are highlighted in red, for example, California pays their CNAs higher on average than most of these other states listed, but yet their quality outcome of number of hospitalizations per 1,000 long stay resident days is above the national average, higher than Virginia and higher than many other states. So, and we can go back to this slide after we review the initial discussion or after these observations for some discussion. But in conducting our research, we found a few observations from the data and the experiences of other states that are worth taking into consideration in this discussion. While nursing assistants are concentrated in nursing homes, they are paid similarly or less than nursing assistants in hospitals, assisted living facilities, and home health. Many states that have passed mandates for staffing ratios have had to do so with a waiver system that allows facilities to request regulatory relief based on regional staffing shortages and other allowed exemptions. Facilities that cannot meet mandates may be forced to turn down admissions, and in the world of COVID, we already know that that's an issue in some communities across the state, so definitely something else worth taking into consideration. As I mentioned in the previous slide, higher staffing ratios and pay does not necessarily equate to quality, and depending on a state's mandate or facility staffing structure, more emphasis may be placed on traditional nursing care to meet mandated ratios rather than personal care if there are, in fact, CNA or personal care shortages in the area. As I also mentioned, a higher Medicaid expenditure per enrollee does not necessarily guarantee higher wages nor equate to high quality outcomes. And ultimately, mandating ratios does not solve the financing, recruitment, and retention infrastructure needed to adequately support our nursing home staff and, most importantly, the residents. So with this data and this research kind of taken into consideration, our team has looked to develop a few opportunities for recommendations and discussion by this group. And really, we want to reinforce the fact that quality of care, patient satisfaction, and staff satisfaction are key to these discussions. And we also have to take, I think this was mentioned during somebody's previous comments, equity is critical in that a lot of our workforce comes from different communities across the state, and we need to ensure that in our recruitment retention strategies, we take that into consideration. So a few opportunities to maybe increase the quality of workforce and to really provide our workforce and CNAs with the tools that they need. There's definitely some opportunities within our current CNA regulations to require that continuing education be required for recertification. In addition, there's only a minimum of 40 hours of clinical experience required for certification, and that's probably lower than a lot of other clinical certifications and licensure requirements across the state. So that could be worth visiting to really give CNAs the concrete experience they need to really get out there and be on the boots on the ground with the experience that they need. And then in addition to that, there's no current requirement that any CNA training or education program requires that CNAs be a part of that CNA education and training team. So as you all know, probably better to have a CNA be involved in that hands-on education of other CNAs that are entering the workforce. The next level of this could be to look at, and I know this has been a key topic throughout this work group, is to develop recruitment and retention strategies from career ladders. And I know there's been discussion on working with our public education system to provide outreach and recruitment. And then there's the financing discussion. And really, I think there's an opportunity to provide incentives to our facilities to better invest resources into recruitment, retention, because as we know, the workforce just isn't there today. So we've got to find a way to bridge that workforce shortage until we're able to invest in intentional workforce development initiatives. And then afterwards, we could potentially look at exploring what statutory or regulatory opportunities there are to look at these staffing ratios. So Rebecca and Dr. Pratt, that's kind of, I wanted to get through that fairly quickly and then leave the table open for discussion for any members of this work group.
Yes, I have a question, please. Can you hear me all right?
Yes, sir.
I think you said that they were 3.8 hours in Virginia as far as care on the residents.
Yes, sir. That says reported to CMS.
And that is determined, if I'm not mistaken now, by looking at the actual payroll records. Is that right?
Yes, sir. I do believe so.
Okay. Within that, when an office staff member or a bus driver or an activity director has their CNA license, they're also counted in that number, even though they may not provide the direct care on an individual. Isn't that correct?
That I am unsure. I'm not sure if it's if that is taken into account or if it's strictly just based off of payroll, or if it's payroll employees that are actually providing direct care. We can definitely look into that.
Well, from all research that I've done, those are counted as being staff, but they're not actually doing any direct care, and that leaves the CNAs that may have a hall with 20, 30 residents or so by themselves, even though, it looks like there's more CNAs on duty. They're doing bus driving, or they're working in the office, or maybe even the kitchen. To me, you really can't go by that to get an accurate picture, because, there's so many residents that aren't getting fed or aren't getting their brief changed or whatever. I just wanted to make that comment, and I thank you very much for your input.
I also have a question. This is Sam Cookage from Dignity. Within these statistics and research that you've done, do you also incorporate the 100 nursing homes that are on the watch list for inadequate, for problems, for the less than 2 hours of care per day? What do you do with those facilities? How do you incorporate those?
So for all these states, that they are statewide averages for all the nursing homes reported into reporting to CMS, and we do understand that not only are there probably regional variations that could potentially skew the data, we also understand there are always going to be outliers, and that those outliers are not taken into account in this data. This was more so intended to paint a picture of the system as it exists today, and we understand that there are certain facilities that do not perform as well as others. I think there's obviously the opportunity to built-in mechanisms to help support those facilities and support the workforce to go to those facilities.
Well, with regard to that, I would think 100 out of 250 is not just outlined. That's a third of them. I mean, that's a large amount.
I would agree, and I wasn't intending to say there was only a handful. We do know that there are staffing shortages across the board in a lot of our facilities, and that's why we really took these recommendations into that stepwise, tiered approach, because we understand how critical that workforce recruitment and retention is, and the workforce development. I think there's a lot of room to go there, but I think the intention of this data was to make sure that we all understood that there's no clear dots between staffing numbers and quality from a statewide perspective, and that we really have to take very individualized approaches into working with these facilities and addressing gaps at the local level.
And I think that's important too. However, I guess the one element that I feel like we have overlooked is the element of why are so many people leaving. It's not about getting more people in. If the tires keep blowing out on a car, you just don't keep replacing them. There must be a reason. And I don't know that anything has come forward with respect from the panel. I mean, I know a lot of people on my team, Dignity for the Aged, have done extensive research, and we have a lot of statistics that haven't been brought up. And I'm wondering why that was not included in this. Why people are leaving, not how do we get more in.
Well, and I think and I know this was mentioned during the conference period earlier. I know that the retention is a huge part of what this group has discussed and is focused on. And I think, in addition to obviously the pay ranges, also looking at other retention strategies, such as developing these workforce career ladders and providing opportunities for not only professional growth but also looking at opportunities to grow up the ladder into managerial positions and so forth. And I think this group is well positioned to really hone in on that retention discussion as well.
Right. And do you think in conjunction with that we could, how do we start encouraging the people in the field right now? It's really hard to say what we're going to do in the future, because the people right now with boots on the ground are doing an amazing job, and they are sacrificing everything, including their own health. And yet, just like Erin said, I mean, to be honest, she's a CNA, and she took time out to make a comment for this meeting. She's back being a CNA again. How do we encourage the people in the field right now who are breaking? I mean, what can we offer them other than a job at a fast food factory where they don't have all the stress and they get a better pay? What do we do for them?
I think it's a great question. I do know that the discussions that have occurred and kind of as a result of the current pandemic, I know a lot of the discussion about how to allocate those CARES Act dollars have been geared towards supporting the boots on the ground workforce and through hazard pay and bonuses and so forth. And I think that those conversations are continuing to evolve. And I think you're absolutely right. The number one concern right now is burnout and making sure that we're not only making these individuals feel, but that we're providing them opportunities to grow within their current roles. And I think in conjunction with this working group, there's a lot of findings that are being realized through the pandemic and what we're trying to. I think it could be an opportunity to springboard a lot of discussions on that retention, in addition to highlighting the value to increasing pay and how do we actually, what mechanisms are there to do that. And I think that a lot of groups are exploring that, especially in light of the CARES Act funding that's going to the state right now.
And how will those conversations take place? Because everything I hear is we don't have the money, we don't have the money. And not only that, with that, COVID really has kind of done the nursing homes a favor in a bad way, because the nursing homes had problems way before COVID. My mother-in-law died in December of this year, and she was in 5 different homes. I would go in and the care was just nasty, terrible. I can't even go into it. It was so bad. We put her in 5 different homes. I think part of the problem is, you have brochures that say we're going to care for your loved one, and that's what That's what the selling factor is, that we wanted to find some place that would care for her. After 5 homes, we finally found one, but she nearly died in the process. So what happens is it just seems like there are a lot of investors who are making money off of nursing homes. They seem to be a front for making money, but the people who give their life to serve these elderly people aren't being cared for, and the people who are in them are dying. And it doesn't matter because, after all, the baby boomers are coming up next. We have a whole other crop of people that we can buy nursing homes for and create money. I mean, that really, if you look at the private equity firms, they're having a heyday. So I think we should look at the whole picture. It is about the bottom line is the CNAs and the elderly, and yet they are the ones getting the least attention.
I agree, and I definitely appreciate the comment about essentially the double-edged sword that the COVID pandemic has brought on the nursing homes and exacerbating the challenges, but also providing an opportunity to really spotlight where improvement is needed. And I do think a key element of this kind of draft recommendation or opportunities for recommendation table is really to work with all the partners at the table to think about those payment mechanisms to incentivize increased pay. I think, we don't need to get into the weeds of home finances right now. I think there's opportunities to really tie funding directly to CNA care to really not only will that help with the retention, but also the recruitment in it. But I completely agree. It definitely warrants many further discussions. I think that hopefully what's going on with these CARES Act funds as we begin to think about how to spend those more meaningfully, I think there's the opportunity to leverage what we find through those discussions and future planning efforts as well.
Other questions for Brendan Rivenbark?
And this is Jen Kiggins. Thanks so much for joining us today and for your presentation. It was great. But a couple questions for you. Do you know what percentage of our residents or patients are Medicaid in the state of Virginia? In nursing homes?
Offhand, I do not. I know we've got some of our partners from the associations on the line who can probably provide more accurate data on that. I want to say through some of the other long-term care planning work, and I don't want to misspeak. I want to say it was either 60 or 80 or somewhere around that percentage. Definitely will defer to our associations who probably have more accurate data on it. So.
Well, it was greater than 50%. I think I've heard, around those numbers too. I want to, between 60 and 80 sounds about right, although I'd be curious as to a more accurate number. But so I guess my question is, you mentioned about in the initial observation section about the higher Medicaid expenditures per enrollee doesn't guarantee higher wages for CMAs nor improve, nursing home quality outcomes. And just in talking with some of the upper administration from long-term care facilities in my area and just my experience, is there, and they all will say, well, there's not enough Medicaid money out there because there's so many of our residents are Medicaid patients. And so just throwing Medicaid money, which Medicaid is already stretched pretty thin, I know in Virginia these days, but is there a way to earmark that Medicaid money so that it can go for things like higher, wages or improved outcomes? Is there a way to do that?
I definitely think there is, and I think you also bring up a good point. I didn't probably highlight it as much as I should have, but I think really taking a braided approach to this, because as that data says, whatever that ratio is, not all long-term care residents are on Medicaid. So to take this from the approach that Medicaid is the only financial lever to help us get there, I think would be a little bit of a missed opportunity. So I think that's really when we can also get the other private insurance companies around the table, but also the hospital groups. As we all know, we're venturing into this world of value-based payment, and although the nursing home world isn't there as much as others are right now, I think there's the opportunity to really have this conversation on how do we start sharing resources a little more intentionally. And I totally agree. I think Medicaid is a huge lever for that, and I think it's worth having that discussion with Medicaid on what's their appetite for furthering this discussion, especially as data becomes more clear on where the return on investment is. But I think there's definitely that opportunity.
Yeah, and I only bring that up because just in my experience working in different facilities, you know, as a nurse practitioner, I think that that the ones that are private pay, you know, there's some really nice facilities out there, and they tend to be ones that are not Medicaid heavy. So, and the ones that are a majority of residents or patients are Medicaid, I would venture to say are not maybe our nicer facilities. So that are adequately where the staff stays when they're in a. Or I know myself as staff, you know, we stay when it's a nice place to come to work. You know, it's clean. They've got an employee cafeteria. They've got, you know, plenty of parking. There's, you know, all the little things that go into where is the place that we want to come to work every day and we want to stay at work. And yes, a lot of it has to do with administration, absolutely pay, but a lot of those little things and just making it, you know, a nicer place for our employees to come to work. So just, again, in my experience, and I think some of our Medicaid facilities just have a long way to go to making it an appealing place for our staff, from our CNAs to our providers to our administrators, you know, to want to stay. So that's the only reason I ask about Medicaid facilities and what percentages of residents are Medicaid, because I think they have the most to gain from, or the longest way to go for areas for improvement. So if we're going to focus anywhere, but I agree with you, and I think hospital systems, you know, as well, it's kind of a group effort, but just to keep that in mind. But thank you.
Are there other comments?
Brendan, this is Rebecca. Randall Stamper is having a little bit of difficulty with his audio, so he sent me 2 questions in the chat that he'd like for you to answer. He says he'd like to know if there are knowledge and skills that CNAs are lacking coming out of training that we could focus on, and what are some examples of clinical hours from other states?
Thanks, Randall. I didn't get into the nuts and bolts of what clinical hours are for other states. I do know that for other workforces that we're looking at least from the VDH perspective, an example of that, and although it's not necessarily clinical care, but even for community health worker type models and others, we're looking at least a few hundred hours where we're still going through those stakeholder engagement processes, and I can definitely work on investigating what other states are doing. As far as kind of the core competencies, they're loosely defined in our regulations, and I don't think it would be best for me to speak to what those shortfalls are. I think that would definitely need to be a discussion between a pretty diverse stakeholder group, similar to this, probably also with CNAs that are on the ground thinking about what education would be valuable for the incoming workforce and so forth. But I definitely think there's that opportunity to revisit what those core competencies are and how do we reevaluate those and think about what the current workforce needs, but also the future workforce.
Ms. Allen, do you have other questions that have been sent to you electronically?
No, I'm not seeing any additional ones in the chat. So, and I don't see any follow-up questions from Mr. Stamper either.
Are there any other questions from the group?
I have a question. This is Sam Kukich from Dignity again. I guess, you know, when you talk about different states and this and that, with respect to, this seems to be, I asked Erin, I said, Erin, do you feel you weren't trained enough? She goes, oh, no, I was trained enough. I just can't do it all. So I don't know. I know we keep coming back to training, and I'm sure there are some people who don't receive enough training. But I think if we keep focusing on education, you could be as educated as all get out and just not have enough hands or time in the day, and the care's not going to be there. And that's the thing that I keep coming back to is, you know, Erin said, oh, it has nothing to do with training. It has everything to, and I'm not saying everybody can use training. I understand that. But first thing is that there's just not enough people here. And when I listened to her, I know she was ready to break down and cry, okay? Because this is what she's living.
Thank you, Ms. Cupich, and I definitely hear that, and I think that's why it's critical to look at this as not there's no silver bullet, and not only is it recommended that we take this multi-step approach to supporting the workforce, but it's imperative that we do, because there's no one-size-fits-all approach to this. There's no funding mechanism that fixes everything. There's no workforce development mechanism that fixes everything. It's all these pieces working in concert with one another. And that's why I'm hopeful that this kind of stepped approach will give us kind of a roadmap for policy options, some shorter term than others. Obviously, we need to use this opportunity to think about what our workforce that's on the ground now needs. But as far as just really planning for the future as well, I think taking this step approach, looking at it through the multiple legs of the stool is going to help get us there.
This is Lionel DeCure with Dignity for Age, and I would like to comment on that also. Education and training is very important, but that needs to happen after we get enough staff, that we have enough staff just to feed the residents, to bring their water, to answer their call light, to change them not every 6 hours when their brief is just soaked. That training is important in education, because there's so many more things that our CNAs could be educated about, so they can tell the nurses what they observed. But like Sam was saying, that's right now the crisis is there's just not enough staff to feed them, to bring them water, to answer their call light, to keep them from falling out of their wheelchair or bed. And that's where the emphasis needs to be. And then when there's more staff, sure, there's so much more the CNAs could be taught to recognize how someone is deteriorating, or what a bed sore, the difference between a 1, 2, 3, 4 stage bed sore or what, and how to help that. But right now we're just in a crisis with getting them fed and bringing them water and helping them. Thank you again.
Are there other comments or questions? Thank you, Brendan, for your presentation. At this time, we will have recommendations to date from Ms. Allen that summarizes the potential work group recommendations that have been brought before this group at prior meetings. Before Ms. Allen begins, she will cover how the work group will decide upon recommendations for inclusion in the report to the General Assembly. Ms. Allen.
All right, one second. I have to retake the presenter role so I can advance the slides. Okay. So before we begin the discussion about the potential recommendations before this work group, I just wanted to make it clear as to how we're going to go about deciding what recommendations do and do not end up in the final report to the General Assembly. Each stakeholder, by which I mean the organization or agency, gets one vote per recommendation. For that reason, your organization or agency is going to need to designate one person to cast the votes on your organization or agency's behalf. You are free to decide on the method by which your organization or agency comes up with its position on a particular recommendation. For example, you're welcome to poll your members. If you wanted to have, let's say, a group of your senior management have a discussion and have them decide on it, you are completely free to come up with however your organization is going to decide which way to vote. But regardless of how you decide, it's going to be one vote per recommendation per stakeholder. I will be sending an electronic ballot essentially to your designated person to vote on. the recommendations. For that reason, we will need to know who to send it to. So if you could please send the name and the email address of whoever your designated person is going to be to Dr. Pratt and I on or before September 8th. That way we make sure that we've got one designated person per stakeholder, and if we are missing anyone, that we have time to circle back with them and get them to give us that designated person. The voting options for each recommendation is going to be either support, oppose, or abstain. For a recommendation to be included in the work group report, the vote must be a simple majority in favor of the recommendation. As a reminder, the votes are public. If a stakeholder group is opposed to a recommendation, you may submit a written comment that explains your dissenting viewpoint, and that will be included in the final report. And just as a reminder, these recommendations are to the General Assembly, and the legislature at the end of the day may choose to move forward with all of our recommendations, some of them, or none of them. And I would just like to remind everyone what the mandate of our work group is, which is displayed, well, yes, which is displayed on the screen for you. That the recommendations are supposed to be about increasing the availability of the clinical workforce for nursing homes in Virginia, and the report goes to the respective chairs of the Senate Committee on Education and Health and House Committee on Health, Education, or yes, Health, Welfare, and Institutions. When that report is filed with the General Assembly, we will have fulfilled our mandate at that point. If there are particular recommendations in the report that you feel strongly about one way or another, any further advocacy on those recommendations is the responsibility of the individual stakeholders. So if you are strongly in support of one of those things, then it's going to be on you and your organization to work with other stakeholders, with individual legislators to see that carried forward. The work group's work ends when the report is filed. So I just want to make sure that's clear to everyone. For the remainder of today's meeting, we are going to be going over recommendations that were discussed prior to this meeting and adding any additional recommendations that you all would like to see as something to vote on as a potential recommendation. And of course, to make sure that the phrasing of the recommendation is clear so that everyone knows what they are voting on. The discussion today is not whether or not it goes into the report. The discussion today is making sure that the recommendation is phrased so everyone is clear on what it is and so that it shows up on the ballot to vote on. Okay, I just want to make sure that everyone's on the same page, that we're not trying to eliminate recommendations today. It's just trying to make sure that the list that we have is what we're ultimately going to be voting. All right? So with that being said, you may hopefully some of these seem familiar to you because we have discussed them at prior work group meetings. So the first recommendation that I have here is permit, but not require, local school boards to offer graduation credit for service learning. This is one of the very first things that we talked about. Is this clear as to what we are trying to say? You may recall when we were talking about the service learning piece of it, some states require it from the State Board of Education on down. Some states make it optional. Some states leave it up to the local school board. This option is talking about leaving it to the discretion of the local school board whether or not to offer graduation credit for service learning. Is there anything about this phrasing that is confusing to you all that needs to be cleaned up so that everyone is clear on what they're voting for?
Question. This is Sam Cook.
I'm sorry.
Yes, I have a question.
Sure.
Is it well known what service learning entails, or do you need to be more specific there?
That is a good point. I think that it would be best. Hang on a second, let me flip to a new page. I think it would be best to come up with a definition of what service learning would entail. And I think the best way to do that would be to look at the other states that do have either an optional or a required service learning requirement. I believe, I know DC definitely has a requirement that they have to do it, as does Maryland. I think those are the only two states when we talked about it. So I will I will look at the definitions that are out there right now for the states that do have it either as an optional or a required one, and I will refine this as well as the one that's after that talks about service learning, these three right here that talk about service learning. I will draft a definition and have that available for the next work group meeting so that it's clear what the service learning is about based on what those other states have defined it as. I will say as a general rule, just based on my recollection of what we talked about in July about this, is typically it is the service learning is not simply volunteer hours. It's usually some sort of structured program of volunteerism. So I do know that is a component of it, but like I said, I will go back and pull that from the other states and have and tweak what this is to define what the service learning is.
And this
what
is
we
Carol.
mean by it.
I think it's smart to allow as much leeway as possible to local school boards to offer this credit, because this is an incentive for school boards to participate in this learning requirement. And I want to be careful that we don't get too prescriptive, because we want to keep this open and get as much participation as possible should this be a recommendation that is put forward. So I just caution that our definition of service learning might be inclusive rather than exclusive for school systems.
Okay. Yes, I agree.
In conjunction with that, I have another question. Because it is a school, would they, I guess what I'm saying is, would they have a report saying what they did so historically there could be some standards set that say, okay, this person did, fulfilled these requirements to get credit. Just like in any class you'd have requirement. And plus it would provide some historical data on what the actual person did for future. So I think having that defined, I don't think that should prevent anyone from seeking it out, but at least give some structure to it.
I agree, and I think because, like I said, as I'm trying to recollect what we talked about nearly 2 months ago when we were looking at the other states, I know they all had some language about it being a structured program as opposed to just showing up and like doing volunteer hours and getting the hours signed off on. And as part of that structure, there is some I don't know what you want to call it, in-product, thing that must be produced to show what they've done and what they've learned as part of that service learning. So I do agree with you. There does need to be not only for consistency to make sure that that students are getting the credit that their peers receive for the same work, but I also think it's important for data and for research as well to be able to see where they're getting their service learning at, so we can, if need be, refine it in the future to get it to be more targeted.
Yeah, that creates a standard, because that's what you want. You want everyone to feel like they've achieved something.
I agree. Okay, yes. I will, like I said, I will bring a service learning definition to the group next time that is, like I said, incorporates what our sister jurisdictions have done, but is hopefully broad enough that we're not putting ourselves in a pigeonhole, and that has that accountability standardization element to it, so that if school boards are implementing it, like what they're doing in Henrico County is going to be the same as Goochland County, if both school boards opt to go forward with that option. So that would, the service learning definition, I think, should be the same regardless of whether bullet point 1, 2, or 3, or all three, it doesn't really matter, are agreed to by a majority of the work group. I think the definition should be the same for all of them. I will say that the Fairfax County one, their service learning project model is hours based. I will have to go back and see what additional standardization there is to it. But that is, I do know that theirs is hours based because I checked that this morning. So I'll create a definition for service learning. Are we otherwise okay with how the first bullet point is phrased, or?
Rebecca, this is Randy. Can you hear me?
Hear me now? Hello? My audio just cut in and out. Sorry.
Yeah, we could hear him.
Okay.
Okay.
Yes, yes,
y'all
Mr.
can hear me?
Stamper.
Hey,
Yes.
I've solved the audio trouble. So my question was, with the first 3 bullet points, all focused on service learning, the first one would permit local school boards. The second one sounds like a statewide expectation. Do we need to have some balance about either or on these? If we were to do all 3, it seems to me that there's a contradiction between at least 2 of them.
I agree that that you could potentially have conflict with these, particularly 1 and 2.
Yeah.
But I guess, well, first off, we talked about all 3 of them, so that's part of the reason why they're on the list. But also, I hesitate to only put 1 on the ballot of choices of recommendations that we could make, because if we put 1 on and not the other 2, and that 1 does not get a simple majority, well, then there's no service learning recommendation at all, when it's possible
Right.
that one of the other 2 may have achieved a simple majority had it been included on the ballot. I just think when you have these sorts of similar recommendations, let's say 1 or 2 or all 3 get through, that in writing the report to the General Assembly, it should be made clear, like, these are options for implementing service learning. All 3, all 2, 1 of whichever, has been recommended by the work group, and any one of them would be an acceptable solution to implementing service learning. We're just giving you, here's our recommendations. They are options, which, again, we'll just have to be very clear in how we draft it, that they're not intended to all be implemented all at once immediately,
Right.
and that some of them may exclude the other one. I just think it'd be a question of how clearly it's drafted, that these are, you have your choices for service learning. You can pick 1 or more, but if you're going to pick more than 1, you got to be careful how you write it.
Right.
So
Yeah.
you don't create a conflict.
I think for all the voting members to be very clear that there may be some if-thens that have to be explained, that if you vote for this, it may well preclude this other option. And the other question I had is has VDOE weighed in on these sorts of options, or should we approach VDOE as we start to draft?
So VDOE, Dr. Pratt, correct me if I'm wrong, you had reached out to VDOE about the service learning component back in July. Am I remembering that correctly?
That's correct.
Okay. And it's my recollection, and again, please correct me if I've got this wrong. It's my recollection that based on the feedback from DOE at the time, was that this was not a thing in Virginia. That there certainly was the opportunity, if local school boards wanted to come up with a volunteer program or service program, but it would not count for graduation credit. That was the one thing that I think they were very clear about, and I'll go back and circle back with Dr. Pratt about that. But I think they were very explicit about, they can have a volunteer program, they can, I think they can set it up so that it may be like an extra, like what Fairfax has done, for example, like the students that they have here, they have a required amount of hours that they have to get for volunteer. But if they want that optional diploma seal that they get, there is an additional step that they have to do that makes it more formal to be a service learning project. Does that make sense?
It does.
But
Thank you. I
it's not
appreciate
graduation. Yeah, it's not graduation credit. It's just an extra, I don't know what you would call it, flair for their diploma. It doesn't. Yeah. Yes. That's thank you. Not flair, endorsement. Yeah, it's an extra endorsement on their diploma, but it's not. It doesn't translate to academic credit in any way.
Got it. Thank you.
Mm-hmm. So the difference, just so everyone's clear, the difference between the first and second bullet point would be that the local school board would have more discretion in setting what the value of the service learning is, whereas the statewide option means that the state Department of Education, Board of Education, they get to be the ones to set what the value of the service learning is in terms of academic credit. That's the difference between those two options. And then the third one is, as I just kind of went over, is a little bit different because it's not, there's a minimum amount of service hours, volunteer hours that have to be done by students in grades 6, 8, and 12. And then if they want to go a little bit farther in grade 12 to get that optional diploma seal, they can, but it's, again, it's not academic credit for that one. That's just an additional endorsement for their diploma. And to be clear, there's nothing that's preventing local school boards right now from implementing the Fairfax model. But the way this third recommendation would be is that it basically would take this discretion away and just implement it statewide as an option for all diplomas being awarded. Any questions on those so far? Okay, hearing none. And I know Ms. Kukich had brought up, I think, during our very first meeting, that she had encountered a situation where she had, I think it was students, but it may have been adults as well, who had wanted to volunteer to do work in nursing homes, but they'd been turned away because there was concerns about whether it would be permitted under the regulations. Am I recollecting that correct, Ms. Kukich?
Yes, that's correct.
Okay. So one of the things would be, so by required changes, that would be a statutory change to the particular code section that talks about what the regulations for nursing homes would be. And so that would be that it would have to permit volunteerism and or service project learning in nursing homes. Again, if you're going to have, the service learning piece as a recommendation, it's probably wise to have service learning, to have them being able to do service learning in the facilities themselves, with, of course, appropriate supervision, since we're talking about students in this scenario. Would you want these two split out as separate? So one would be required changes to the nursing home regulations to permit volunteerism with appropriate supervision, and then a separate one that is required changes to the nursing home regs to permit service project learning in nursing homes with appropriate supervision. Would you want those split?
I have a question.
Sure.
Sam Kukich again. All right, so who creates, I feel like nursing homes right now are overwhelmed with just trying to get the job done. So if you're going to have these volunteers, who's going to be in charge of the volunteers, and who's going to create these service project learning situations?
So I'll take the service learning piece first, and then I'll circle back to the volunteerism, because that's a little bit broader to my mind. The volunteerism could be both students and non-student adults. The service learning piece would be students. So for the service learning piece of it, the required components of what would be service learning would be set by well, depending on how it gets done, either by the local school board or through the state Department of Education. They'd be the ones to set what the parameters is, depending on which one we went with here, or either one. So they would be the ones coming up with, like, so here's what the parameters for the service learning project is. This is the sign-off that you have to get to prove that you did whatever the service learning project is, et cetera. So they would be the ones making sure the students are checking off the boxes that they need to check off to prove that they've done the service learning component of it. Now, for the actual supervision of those students in the nursing home, and I, of course, welcome any of the industry folks to pipe in, my thought would be that, there's that the staff, and I know that's a bit of an ask during a pandemic, but under normal circumstances, that there would be some member of staff who has the supervision authority for those students when they're in the facility.
So,
certainly
okay,
now,
so
I'm sorry, go ahead.
that would, to be honest, that would be a whole other position to me. If you have kids coming in to volunteer, I would think you couldn't just say, oh, yeah, you handle her today. I mean, because they're, depending on the different levels of students, I just feel like this would require an independent position to handle this, because CNAs don't have the time now. So it would have to be a designated position for this.
This is Melissa Andrews from Leading Age Virginia, and I just wanted to mention that there are communities that have volunteer services directors. So that is a full-time position. So it sounds to me like this would fall under their scope.
Good.
I'm sorry, Ms. Kukich, you cut out right there. What did you say?
I said, I guess that's good. I had never heard of that. I know they have activities directors, but I've never heard of, anybody in charge of volunteers. I haven't seen that yet. So that's wonderful if they have them.
Yeah.
Right. And oh, go ahead, Dr. McDaniel.
Yes, I was just going to just say, yes, they do have volunteer services, and they would welcome anybody that's coming in to help out. Most of them anyway, I know.
Not to, just to give you some insight from my experience, but this is Sam again. Like I said, my mother-in-law was in 5 homes, and there was not a volunteer program in any of them. So I'm happy to hear it, but I don't know that that's standard, because I have a lot of experience with the local homes. So that's wonderful, and I think that idea maybe should be shared with more homes.
And it could be, and I'm just thinking out loud, with the reason why I put with appropriate supervision in there is I'm just thinking of, students under the age of 18, no matter how mature there still needs to be a supervision element to it. But it could be that as part of the changes to the nursing home regulations, that the regulations actually spell out, like, if you're going to have X number of students in apologies because I did not go to school here in Virginia. I'm going to say semester. I assume semester is accurate. If you're going to have X number of students in your facility per semester, then you need to have a staff member who devotes X number of hours per week, which either means you hire someone new or you shift around job responsibilities to make sure that it happens, however you're going to do it. X number of hours per week to supervise those students when they're there, or those volunteers when they're there. If you wanted to be more explicit about what the appropriate supervision meant. When I wrote it, I was just thinking of keeping an eye on students under the age of 18, and then, of course, with the volunteerism, just, they're volunteers, they may not actually have you don't want them doing things that, they would need a license for example. So you need someone to, keep an eye on them so they're not going too far in the help that they're trying to provide, and also to intervene if they're getting out of their depth, even if it's something that could be done. But so with this one about requiring changes about the, their interest, I mean, and I can write two separate ones if you would prefer. I can write one that's with appropriate supervision, and then I can write a recommendation that's more explicit about appropriate supervision entails the following. I mean, I can go either way.
This is Vivian. I think that it should be explained, so I think that would be a great idea. To do two.
To do two, okay.
And the more I think about it, I believe, and I may be wrong, but the facilities that I have dealt with or consulted, been a consultant for, if they do not have volunteer services, a volunteer director, they may not accept these students. I have to go back and look and see what was written there, but I think that is how it was. If they do not have volunteer services at that facility, they don't accept volunteers.
This is April. Hang on a second. Can you guys hear me okay?
Yes.
Okay. I'm getting a horrible echo.
April, I can hear you without an echo if you want to try again.
Yeah, so I just was going to share that, we do, from a federal standpoint, have requirements around volunteer programs. And so, while facilities might have a volunteer coordinator, a lot of times they do use their activity director to fulfill that requirement to oversee a volunteer program. But I know with the building that I actually was administrator of, we had a summer volunteer program for students, which involved a full week, half day of orientation and, really showing them around the facility and orienting them to what their duties would be, of course, also to what they weren't allowed to do. So I think everything that everybody's touching on is right in line. And we do have some great examples across the state where they have very successful activity programs for students.
All right, excellent. And I mean, let's say hypothetically this recommendation were adopted by the work group, the General Assembly puts it into a bill, it gets through, signed by the governor, et cetera. I would say from a regulatory standpoint in terms of writing the regulations, one of the first things we do is look at what CMS has already done in that area, so we're not creating a conflict for facilities, because you don't want to get in a situation where the state says do X and the feds say do Y, and the two are incompatible with one another. So.
Right, and we always have to follow federal, so state it can't, it doesn't trump. We can be stricter at a state level, but we can't, relax any of the federal requirements.
All right, so I will draft two versions of this so that one says appropriate supervision and one is more explicit about what appropriate supervision would entail. And I'll make four, I guess, because if we don't go with the service learning piece of it, or the General Assembly doesn't go with the service learning piece of it, then you'd still want to address volunteerism. So I'll split it out. So there's actually four versions of that. One that's volunteerism, one that's service project learning with the appropriate supervision explained more fully and two additional options. So for the next two, you may recall Heather Anderson, who is with our Office of Health Equity, who I believe is on the call still. Got a long list of people. Yes. She had talked to us about the some of the loan repayment programs and scholarship programs that we have here in the Commonwealth. And one of them, which is the Nurse Loan Repayment Program, this one currently is limited to LPNs and RNs. Is that correct, Heather? I see you on the line, even though I don't. Are you there, Heather?
Yeah, I'm here, Rebecca. There's a nurse scholarship program. I need to check about the nurse loan repayment program to make sure we're not confusing this with a loan repayment program that allows for more disciplines than just nurses. So let me see if I can verify that while we're on the line.
Okay.
But we do, so let me do that. Go ahead and go on with the conversation. Let me see if I can verify this real quick.
All right.
Okay?
Thanks, Heather.
Mm-hmm.
Yes, ma'am. Okay. So while Heather looks at that one, the other one was, as you may recall, that there was a nursing scholarship and loan repayment fund. I really wish these things were named a little bit differently because it's hard to keep them straight. But that one, as you may recall, is with the Board of Nursing. The Board of Nursing is the one who administers it. But there has not been a general fund appropriation. Sorry, someone is that Charlotte?
It is. I was going to be ready to say something when you got to me. Sorry.
Yeah, no, it's all right. Go right on ahead. This is the one, correct? The one that has not had a general fund appropriation to actually fund the scholarship. You're muted, Charlotte. Hang on.
Oh.
All right, go ahead.
I hope I'm not muted now. I've hit it a couple times. Can you hear me?
Yes, we can hear you.
Okay. So, if this is the scholarship fund, the Mary Marshall Scholarship Fund, it's for LPNs and RNs. That is funded. It has been. There has not been a break. We gave funds out every year. We gave funds out in 2019, and we sent the requested funds to, or for those people who had been approved for scholarships to VDH the first week of August. So that is funded, and there are recipients being notified for the year of 2020 for that. And it's a total of $60,000 each year that we send out.
Okay. My understanding from Heather Anderson, when she had spoken to us about the different programs that were going through health equity, that there was one scholarship program that was not funded. And we may need to circle back to this.
This is the only scholarship fund that we're, So I'm sorry. So the only scholarship fund that the Board of Nursing oversees or is the Mary Marshall Scholarship. So if that's the one we're referring to, there is no break in funding for that one.
Okay. I'll wait for,
so maybe
for Heather to get back on line.
Again, making sure the names are correct.
Right. Yeah. Because there were several repayment programs in the various parts of the Code of Virginia about loan repayments and scholarships. So I will double check that with Heather when she hops back online, because I know she said that there was one that there was that the general fund appropriation had lapsed and had not been renewed. So we'll circle back with her when she's done researching. So for now, I'm going to put a pin in these last two here on this slide and go to the next slide, and then we'll circle back when Heather has some follow-up for us. So we have the established education and outreach programs. Hang on a second. Dr. Carter's contacting me through the chat. So Dr. Carter says the Mary Marshall funding comes from Board of Nursing licensure fees, not the general fund. And then Heather says that she can respond about Mary Marshall. So hang on a second. Are you there, Heather?
I'm here,
Maybe?
Rebecca.
Yes.
Yes, can you hear me? Yeah.
Yes, ma'am.
So what we meant when we said it was unfunded is we do get funds from the Board of Nursing, but those are the only funds. So Mary Marshall is funded through the Board of Nursing. There are no other funds that are included in those funds, and I suppose what we were talking about was they could be funded. In other words, the General Assembly could add to that, and I think in years prior, there have been other funds that have gone towards Mary Marshall or scholarship funds, but currently it is just the Board of Nursing.
All right, excellent. Okay, so the last bullet point then would need to be rephrased. So it wouldn't be funding the nursing scholarship and loan repayment fund, which I just checked is the one that is the Board of Nursing one, so that is the right name for it. So it wouldn't be funding it. It instead would be to make a general fund appropriation to that particular fund, the Nursing Scholarship and Loan Repayment Fund, to increase the overall available scholarship amounts. Because, Charlotte, you said it was $60K that was handed out, $60,000?
Yes.
Ooh, yes, 60. Okay. Do you know roughly how many folks received, how many applicants were that received scholarship funds?
I do not know the number of applicants. I can find that out pretty quickly, but everyone who applied got something.
Okay. Sorry, I heard someone trying to talk at the same time there. Who was that?
I'm sorry, Rebecca. It was Heather. I do know how many were funded. I believe we're going to award 32 scholarships.
32. Okay. Okay. So, like I said, this last one I will need to rewrite this so that instead it reads that for the General Assembly to make a general fund appropriation for the Nursing Scholarship and Loan Repayment Fund to increase the available monies to be awarded. So that's what that one would say. Okay. So I will need to make a note to rewrite that one. 1 second. And that was for LPNs and that one was for LPNs and RNs. Is that what you said, Charlotte?
It is.
It is. Okay. And the eligibility for that, I assume, is set by statute, since it's the funds created in statute. I imagine the eligibility is in statute as well for who gets it, the LPNs and RNs.
Yes, it is.
Yes. Okay. So a separate recommendation could be, aside from the general fund appropriation for it, would be to expand the eligibility. So introduce a bill to expand the eligibility so that CNAs could also be applicants for the Nursing Scholarship and Loan Repayment Fund. Because I know one of these was LPNs and RNs only, which is why I had the expand eligibility up here for the bullet point above it, which I may have had those backwards, so I do apologize.
Rebecca, I'm sorry, this is Heather again.
Go ahead.
The Nursing Scholarship Program is for RNs and LPNs only.
Yes.
So that would be the one that you would want to expand the eligibility for. The scholarships are limited to up to $2,000 apiece.
So the first bullet point, sorry, not the first bullet point, I apologize. The second one from the bottom that says expand eligibility, that one is correct?
I'm still verifying the terminology about the loan repayment program. So let me check with that. I might have to get back with you offline. I'm not getting a response. But for the second one, fund the nursing scholarship, that's what we've just been talking about with the $60,000 from the Board of Nursing, and it's for RNs and LPNs.
Okay, so that one could be expanded. That could be a potential recommendation of the group.
Yes, and I wish we were different too.
It is a little confusing. Okay.
It's very confusing.
All right,
Rebecca,
so,
this is Carol. You might want to consider just a phrase to differentiate those two loan repayment funds. You might just put a phrase in there that says funds, or a parenthetical expression that tells which ones of those come from the nursing licensure fees, just so people will keep those two pots of money separately.
Yes. Okay, let me make a note of that. Yeah, because I imagine it'll be confusing on the ballot as it is at this exact moment. Okay. Sorry, just taking some notes. All right, and I'll circle back with you offline about the second to the bottom bullet, Heather. Okay. Next slide. The establishing education and outreach programs for middle school and high school students to promote career pathways and long-term care. So this was touched on, I know, by Leading Age when they were talking about some of the initiatives that they had, but I also believe Megan Green had talked about this as well last time when she was talking about the workforce development program, some of the recommendations from that office. So what changes, refinements do we want to make to this first bullet point here to make it clearer, if it needs to be made clearer, for this recommendation, this first one here? Okay, I'm not hearing anything. Can everyone still hear me?
Yeah, I think it's because it's really well written, Rebecca. This is Melissa Andrews. I think it captures it.
It's okay. I just wanted to make sure, because every now and then the audio will cut out through my headset, and I just wanted to make sure I wasn't speaking just to myself in my office.
No, we're all still here.
All right.
Yeah,
okay.
Are we just on the first bullet, or could I comment on the second one?
You can comment on the second one. Go right ahead.
Yeah, I just think that we would want to clarify funding for advanced certification tuition.
Tuition, okay. For tuition for advanced, okay. And Dana, while I have you here, Dana and Melissa both, what's the projected end date of the pilot program?
That's undetermined at the moment due to COVID. There was the first semester was supposed to begin on August 18th, but had to be delayed due to COVID. So they're hoping for the first semester to start probably in November, but it's just undetermined when that'll be. Everything's up and ready to go. It's just this has to be in person, a majority of it. So COVID is sort of guiding this at this moment.
So do you know, once it gets started, how long it's supposed to run from whatever that particular start date happens to be?
I can send you those dates, the calendar dates. I know that right offhand, but I can follow up and send that to you.
All right. If you would, that'd be great. It wouldn't matter so much for the ballot. It's just so that when, if this does become a recommendation, that we can explain a little bit more detail about what the pilot program is.
Sure. We have a website too that we created for the program that I can send you as well.
Okay, that sounds great.
Okay, great.
Okay. All right. Then the third bullet point. This one also came. I pulled this right off one of the slides that Megan Green had used for presentation at our last work group meeting, which was increasing wages for CNAs proportional to regional living wage standards. So any thoughts on that?
How would, this is Randy, how would the regional living wage standards be identified? Is that through the ALICE report or other means?
I do not believe Megan Green's presentation on this point went into detail about how the regional living wage standards would be set, or how you would measure them. Other than the ALICE report, are there other ways that, so from my perspective, working at the Office of Licensure and Certification, when we talk about regions, my brain automatically goes to the health planning regions, which I know does not match up perfectly with the ALICE reports. So are there other places that you would, other than the ALICE one, are there other ones that you would look at, other standards?
Clearly it's a hotly debated topic historically, but the ALICE report at least is Virginia specific and is based on a strong methodology. I know that MIT has I think a living wage calculator. There are a variety, and I don't know that the General Assembly cares, how it would be chosen, but I would hate to see a recommendation get endorsed and then everybody just kind of holds up their hands and says, "What's a regional living wage?" So maybe a conversation for another day, but it could bite us at some point.
Well, just based on my experience with the General Assembly, I would expect it to be a question during a subcommittee meeting at least.
Right.
If not a full committee meeting, yeah. So for the regional living wage standards, I will work with Dr. Pratt to pull some information together about what options we have to use as like the stick that we're going to measure against for the regional living wage standards that we can discuss at our next work group meeting to see how they break down Virginia, for example, and then what the various metrics say is a quote standard living wage for that particular region, because I think that would be helpful to put into context, because I don't know offhand what's going to be a living wage in, let's say, Roanoke versus Alexandria.
Right.
I don't have that off the top of my head. So I will get that together to give us some options. And it may be that when we put forward the recommendations to vote on, put the ballot together, that you have, one of them is regional living standards according to what MIT's come up with, the other one's for the ALICE report, et cetera. And we'll just go from there. And we would have already discussed what the regional living wages would look like according to those particular sources. Okay.
Thank you.
Of course, yes. So we also had increased funding of Medicaid nursing care services. For this one, I don't know how much more discrete or specific we want to be about where the funding increase should come from. As you all may recall, when DMAS was here at our last meeting, we had several presenters from DMAS, and they had talked about what goes into the rate that is paid, and there's several things. And let me check and see if there's any DMAS folks on the call. I know Barbara said that she could not join us today, but I don't want to misstate anything. But I believe they had said that the direct, there is someone from DMAS in the attendees thing. Hang on a second. That they did say that the direct costs portion of it was the portion that was attributable to staffing costs. And I apologize, I'm going to call on someone here. Steve Ankiel, who's on the attendees list, can you hear me? Okay. Is Terry Smith on the call? Okay, well. Okay, well, in the absence of someone from DMAS being able to answer that question, as you all may recall, like I said, they flashed up the formula for us to show that there was the background checks piece, there's the NATCEP piece, there was also the direct cost piece. Direct cost piece being the one that is the staffing cost. So we could, if the work group has an interest, when it comes to increasing Medicaid, funding of Medicaid for nursing services, being specific about the funding needs to be for the nursing care services direct costs and not just, the number goes up for nursing care services without specifying what part of the formula it's going to.
Yes, this is Lionel DeCure, and I have a question about that. Are you talking about like the amount, like I forget what it is for Virginia, so much a day that the nursing home gets from Medicaid? Is that what you're talking about?
Yes, that is the rate that I'm talking about. So I'm flipping right now to see if I can find my notes from, or excuse me, not my notes, the presentation from the last meeting. There's a daily rate, and then there's an adjustment to the daily rate based on the
right. Yes,
So-
and my question would be, what would keep the investors of the nursing homes from getting that money and the money not being able to be used for increased staffing or a fair payment to the CNNs and nurses? What would keep the investors, if you just give them increased funding and they give it to the investors, what would prevent that?
I do not have an answer to that question. I would defer to DMAS, who again I'm not sure. The one DMAS person I can see in our attendees list is not.
Yeah, I'm sure all those investors would love more money, but it wouldn't help to increase staffing or to help pay the retention of the CNAs and nurses because all the investors would just get the money. Thank you.
Thank you, sir. Hello?
Yeah, this is Brendan. I could speak to that for a second, and our associate partners might be able to reaffirm what I'm saying. But the way I understand it, that Medicaid reimbursement doesn't go to facilities unallocated, and they have to be allocated towards defined expenditures, and the facilities have to submit invoices for where they're spending their dollars. So I am certain there are mechanisms within that invoicing and reimbursement structure for which that could be addressed.
Well, from the experience and what all I've read and learned, unless it's specified exactly, it's not going to go to where it should go.
So hang on a second, I've got too many windows open. So for this one, the increased funding of the Medicaid nursing care services, in terms of specificity, I think it would be a good idea to say that it's the direct cost, because that is part of the formula that DMAS had showed us. The direct cost is the nursing and ancillary services times the RUG case mix, which is separate from all the other bits that go into the per diem rate. But also, and I'd want to talk to DMAS, and I will reach back out to Barbara Seymour. Like I said, she wasn't able to join us for this meeting. To reach out to DMAS to make sure that this recommendation that if there is an increase of funding for Medicaid nursing care services for the direct costs of those services, that it's going to that purpose, I would want to get DMAS to assist in rewriting this particular recommendation so we're not writing something that's unworkable or DMAS would have a hard time trying to interpret. I think it'd be helpful to get their input on how to write that to make sure that it is something they can do and is explicit enough that they know what is expected if that legislation were to come through. All right, and just as an FYI to everyone, Randall Stamper had to leave the meeting to join a different teleconference call. So if you all have questions or are looking for Mr. Stamper's input, just send those questions my way and I will pass them along to him. Okay, the next bullet point that I have here is, this is another one from Megan Green's presentation about workforce. She talked about establishing financial incentives to support working parents in the long-term care facilities in the areas of child care and transportation costs. And some of the things that she had listed as examples of what that would be the provision of weekly child care stipend, like a stipend for child care, gas cards, for example. So I would love to hear your thoughts on how, hang on a second. on if this needs to be refined or narrowed a little bit more, or made more specific, I should say. Okay, I'm not hearing anything on this, so I'm assuming it's fine as written.
Actually, this is Sam Kukich.
Yes, go ahead.
Okay, financial incentives to support working parents in the areas of child care and transportation costs. Well, who are we talking about here?
So this would be this would be employees, apologies, this would be employees of the nursing home, and that could be definitely made much more clear. Employees of the nursing home who are working parents.
So, in other words, providing free child care and transportation costs.
It wouldn't necessarily need to be free, and Ms. Green's presentation didn't say that. It was fine. I'm sorry?
I think those incentives need to be defined more, because right now it just seems very broad.
Yes. So, like I said, she had given examples in her presentation. So she had stipends, for example, for transportation, child care. A gas card was something that was explicitly called out. So I don't think, and I don't want to speak for Ms. Green since she's not on the call, and I'm just speaking from what the presentation she gave at our last meeting. I don't recall her saying that these things should be provided at zero cost to the employees, that the child care is totally covered by the facility or the transportation costs totally covered by it. But I think it was framed more in a way of financial incentives, financial programs. I do agree that needs to be cleaned up. That would reduce the financial burden, not eliminate it. It didn't sound like that's what she was talking about, but again, I think I don't want to put words in her mouth, but I did not hear her say that the things needed to be free.
Well, I understand. Yeah, but let me ask you something, and I don't know if this is the proper time to say this or not, but there are lots of recommendations here, and I know that they're not going to pass them all or all going to go forward, but I look at this and say the amount of curriculum development, program development, just all the things that you have listed in here seem to involve a lot of people, a lot of time, a lot of cost, and the time to implement it. How in the world would we approach this? Because funding alone would be astronomical.
So I had mentioned when I was talking about the how we go about choosing which ones we're going to end up going into the report. At the end of the day, these are just recommendations to the General Assembly, and the General Assembly could take all of them, they could take some of them, and they could take none of them. And for any legislator who picks one of these recommendations to develop into a legislative proposal, that is the financial piece of it. That's something that they have to address as part of their legislative proposal. So if they put in a bill and there's a price tag attached to it, then there has to be a budget amendment typically there has to be a budget amendment to go along with it. So that's part of the legislative process is, so I have a bill and there's a price tag, and working with their fellow legislators to get the requisite votes to not only get the legislation through, but also the attendant budget amendment that goes along with it. That's part of, that's their role as legislators, is to enact policy and figure out how to get it paid for. And certainly, our recommendations are supposed to be about increasing the clinical workforce in nursing homes, as we all know. There's nothing that precludes a recommendation. I know these are these recommendations we've talked about so far are, here's an option that that may cost money. I don't know. We're not doing budget projections here, or trying to calculate the fiscal impact of any of these things. There's nothing that precludes us from making a recommendation that is instead, here's how you raise money. Here's a recommendation to raise funds and then devote those funds to this specific piece of increasing the clinical workforce. That absolutely could be a recommendation. That it's just not what's been on these first two slides. And if anyone, not just you, if anyone in the work group has a recommendation along those lines of here's a way to increase money coming in to the state that then can be put to a specific purpose of increasing the clinical workforce, that can be a recommendation. That's part of the discussion today is refining what we have here, but also if other recommendations come to mind, now's the time to bring them up so that they can be put on the ballot for each stakeholder to vote on.
Okay, like I said, I've been a program manager, and I'm thinking each one of these programs would take a long time, curriculum development. How do we take high school kids in here? What appeals to them? What can we do safely? There's a whole lot of stuff, alpha tests, beta tests. I would be dead before this comes about. So I'm like, as far as cost and funding and time to implement it, and that I represent the elderly, and so my heart says, meantime, all these people are dying. So that's what I look at this and say, I know you don't care about this, you don't care. I know that this particular work is not addressing current issues, but this looks like a long time to implement it. And I think of all the people right now who are dying, and I just am trying to connect those dots, and I can't do it because I would think I'm almost 68 now, and I'm thinking, well, by the time you got this program going, I'd be at least 80. Just a thought.
Well, like I said, if you or anyone has recommendations that are more, I'm trying to think of the right word. I don't want to say short term because that makes it sound like it's just a one-time fix, and that's not what I'm trying to imply. But if anyone has a recommendation that would result in an increase in the clinical workforce in the nearer term, which, these are recommendations to the General Assembly for the 2021 session. So you'd be looking at, unless there's an emergency enactment clause, you'd be looking at an effective date of July 1, 2021 on any of these bills.
Well, if I can interject that.
Sure.
I think something simple. I had the opportunity to talk to Dr. McDaniel, and she shared a process with me, and I hope you don't mind me sharing this, Dr. McDaniel, but it's something she's already developed. It's excellent. And we put in something to help the leadership so that we turn around the attitudes and the poor pay. And like I said, we have a quick motto that says, think, do, act. If you think like a professional, you will act like a professional, and you will be a professional. These CNAs, much like what Aaron said, are underappreciated. They feel like slaves. And I'm thinking, we need to work with that. That's some truth we can embrace right now. Think of a slogan that can empower these people to feel like there's somebody, that they have a purpose, not just slave labor. Teach them a quick process. We don't need to approach the whole world to make this work. This could be a quick fix. It could. Give them proper pay. Treat them like professionals. It's like, what did they say? I can't think of it right now, but just say no. That was a quick solution that gave the whole idea. Think, do, act. It's like, think you're a professional. Treat them like professionals. That's part of the problem right now. That's Dr. McDaniels, would you like to interject since I've thrown you under the bus here?
Well, and thank you, but here's the problem, and not so much that it's a problem, but my model is for CNAs to use in long-term care facilities that will help them to be able to recognize when a patient is having a sudden change in status and report it to, categorize it and report it to the licensed nurse so that that patient can be taken care of immediately. So it's different from trying to build the workforce. This will help them now, yes, in their care, in them providing care today. However, to build the workforce, I do understand many of the recommendations because the Virginia Nurses Association Diversity, Equity, and Inclusion Council is working on something similar for nurses in the workforce, registered nurses, licensed nurses, and CNAs in long-term care facilities, where we're doing student outreach. We're preparing to do it right now. And so I do understand. I understand what you're saying as well, Sam, about the model that I developed. But I think what Rebecca is saying is that this is more about how we're going to build the workforce. So I don't mind sharing my information with the work group. But again, I don't know if that's going to help to build the workforce, which seems to be what this is all about. Am I correct, Rebecca?
I also think this would be a great, your process would be a great transitional aspect of moving forward instead of starting something new. Use what you've already, I think we all have something to offer here. And when you told me about your idea, I thought, that's fantastic. Yeah, it's not a be-all, end-all, but it's a great transition. And some of those ideas should be on the slide. Because they are transition. We can't just say, and you have to understand, my group that I'm supporting are people who are in homes right now and they're dying, and I hear from them every day. So that's what I'm passionate about. I am passionate about the future because I may be in one of those places. But right now, I think a transitional piece is necessary. And if you already have developed that, I think it's of value and I think you should share it.
So this, if I could jump in for 1 second, this is Melissa Andrews with Leading Age Virginia. We're all working toward the same goal, and that is the highest quality of care for the oldest among us. So I just feel that needs to be understood. Secondly, not all nursing homes are poor performers. So I think we need to be really careful as I keep hearing general statements about nursing homes killing people, and that's just not accurate. And I feel as an advocate for quality providers, I need to state that. The last is, this is requiring systemic change. I think it's important that what Brendan said is there's no silver bullet. The quality issues that you are offering, Ms. Kukic, which I appreciate, they require culture change within these organizations, and culture change starts with leadership. So this has to be long-term planning. This has to be educating providers of the need for that culture change and why it's going to help them better serve the people who are in their care. So while I appreciate we look for people wanting a quick fix, if there was a quick fix, we would have done it already. It's not that the sector wants to fail the people they serve. It's that this is a longstanding systemic issue. So everything is intertwined. The lack of quality workforce, the lack of funding, the challenges with transportation and being, CNAs who could be a single parent, who could be taking care of an elderly relative as well, working multiple jobs. I mean, there are so many layers to all of this that I think that these recommendations are reflecting the complexity of the problem. Thank you.
Just to be clear, I didn't ask for a quick fix. I thought that Dr. McDaniel's program might be a good transition.
Okay, this is Rebecca again. To Ms. Kukich and Ms. Andrews and Dr. McDaniel's point about the Think Do Act, the need for culture change and leadership, I think those are prime areas for recommendations. I did not hear a specific recommendation to incorporate into the ballot, though. So if we do want to do a recommendation that addresses the retention piece of it through culture changes and change of attitude and leadership, please absolutely let me know what you want to see as a recommendation for us to vote on. That's what today's discussion is about, is refining what we've got, adding others that have come to mind that we want to include on the ballot for us to vote on.
Yeah, this is Sam Kukich again. I remember in one of our first meetings mentioning to you that I thought that leadership really was important. I don't know how, if that's coming up in another slide, but I do remember suggesting that we add leadership to it when we first spoke.
Yes, I recall that as well. For the leadership portion of it, how would you, how would you frame the recommendation? Is it, like for example, on this first slide, or in the slide here, the first bullet point is, establish education and outreach programs for the students to promote career pathways in long-term care. Is it then, would the recommendation be, for example, like establishing, or let's say partnering with, using one of Brendan's examples, partnering with third-party groups to create a leadership program or a change culture program that can be brought into the various nursing homes. Does that make sense what I'm saying? I'm just trying to come up with, I'm trying to figure out how to how to write the recommendation. Does that make sense?
Yeah, I mean, there are lots of culture change consultants out there, and there are a lot of leadership development and, long-term care consultants out there as well. So I think the question is, I mean, there's so many. How do you decide on just one? And then again, where does the funding piece come from? How do you make sure? I mean, I think the issue at hand is there is a segment of providers that we are talking about. And so how do you reach that segment of providers? Because we're not talking about all providers. And so there are resources out there for them. And then in what format do you recommend those resources, or do you require those resources? I think there's so many questions under that, Rebecca. If that doesn't really help, I'm sorry, it more muddies the water.
No, that's fine. It's just that's what I'm trying to kind of get to is there one or more discrete recommendations that can be pulled from this conversation about improving the leadership and the culture? Because if leadership and culture are improved in a positive way, then people are more inclined to stay on, and it improves the retention of a facility, for example.
I think if you did an analysis like you would do for any organization to find out what the issues are, take 10 of the worst performing nursing homes, and there are many of them in the state of Virginia, take them, do an analysis, and find out what they say. Get it from the horse's mouth.
So if I'm hearing you correctly, would that mean, so the recommendation would be that a study be conducted, let's say through the Joint Committee on Healthcare, for example, to have them perform that study so we have that information and can build proposals off of it?
Well, that would be one idea. You could also just develop a survey. Like I said, when my first comment, ask the CNAs. They're in the mud. They're in this environment. They come into it with hearts of gold and come out of it exhausted and burned out. So ask them, do some surveys, take the worst of it and figure out the best of it.
Okay. So, sorry, I'm just taking some notes here because I want to get this all down, and so it's included on the slides for next time to make sure I've gotten your
all you have to do is
down correctly.
There's a watch list with 100 nursing homes on it that are rated at Fs, and Ds. All you have to do is pick those. We have all the data. Just pick those. You can find out what the problems are.
And I get that. I get that list is available, but the point I was trying to get to is what the recommendation is to the General Assembly about it. Like, who's doing the study? Is it the expectation that VDH does it? Is it the expectation that the Joint Committee on Healthcare does it? That's what like I said, the study idea I think is great to include on the ballot, and that speaking to either all the nursing homes or just the ones who are ranked in the bottom third, however you want to do it. I think that's a great idea. I'm just trying to formulate what the recommendation is, and knowing who the actor is helps for these particular kinds of study bills that you're talking about, or study recommendations you're talking about. That's all I was asking.
Right, and that's a good point, because while I'm listening to some of your comments here, I'm wondering who's, when you say establish education and outreach programs, who's doing that? Who's doing all these things that we're suggesting? I don't have that answer, maybe because I assume that you have those answers for these recommendations, because I don't, and I'm wondering how we're going to do this as well.
So for the educational pieces of it, so that's going to be your service learning and all that stuff. That would go to DOE, Department of Education. For the education and outreach programs about career pathways, to my mind, and of course I welcome anyone else to pipe up on this, to my mind that would be either DOE or it would be the Workforce Development Office.
Rebecca?
For your funding, yes, I'm sorry, who's this? Dr. McGannon, yes, sorry.
Yes, I would be willing to volunteer my services to help with any study that you would like to do on this matter.
And I'd be willing to assist you. I would be willing to assist you.
And what I'm talking about is about the leadership and culture change and culture climate in some of the facilities that have lower scores.
Ms. Kukich, the list that you had mentioned, are you talking about the sorry, I'm blanking on what it's called, the 5-star ratings that CMS puts out, or are you referring to a different list?
It's a different list.
Do you mind sending me a copy of the list so I know which one we're talking about? Because the one that frequently gets brought up is the CMS 5-star one, and if that's not the one we're talking about, I want to make sure that I'm on the same page that you're on.
Okay. I will send it to you.
All right, thank you.
I think she's talking about the organization Nursing Home Abuse Advocate, NHAA. It's a nonprofit that gathers information about nursing home abuse and neglect. And you can type in nursinghomeabuseadvocate.com/watch list.
Okay.
Thank you, Lionel.
You're welcome.
All right. So I will, I'll put in some additional recommendations on the studies for culture change and leadership, and I'll include that in our slide deck for next time to make sure I've phrased it in a way that's clear and memorializes what we've just talked about. Getting back to the financial incentives to support working parents, I know I can't remember who mentioned it now. Someone mentioned that should be a little bit more clear as to what financial incentives mean. Like I said, the presentation that Megan Green had given us had thrown out stipends as an example, or gas card for the as examples. Do you all want me to make it more not do you want to make it more, do you want these financial incentives to actually be broken out so it actually says like establish, and I'm not sure who would be the establishing one on this one, but the creation of a financial stipend for, again, nursing home employees who are working parents, just to clarify that, for use in transportation costs or for use in child care costs, I don't know, like a voucher program or something similar? Or do we want to leave it at just financial incentive?
Is it clear what that means when you say that?
Financial incentives or stipends?
I just think it needs to be defined better because incentives could be anything.
Okay. Let me brainstorm with Dr. Pratt on how to break that down a little bit. I know I know Megan Green had mentioned had mentioned stipends, but I think there's other ways that we could break that out beyond just stipends. Like I said, a voucher could be a way to do it as well. And if it's, for example, like a voucher program, there might be existing, at least on the child care side, there might be existing programs that we could tie that to. But I would like to talk to Dr. Pratt a little bit more detail about that, though. Okay. So I will circle back to that one. Okay. The last bullet point that I have on this slide is, you all may recall, we had Department of Veteran Services come in and talk about their many wonderful programs, as did the Department for the Blind and Visually Impaired and the Department for the Deaf and Hard of Hearing. And one of the things that Veteran Services had presented was their V3 program, the Virginia Values Veterans Program, which a component of it is certifying businesses as engaging in veterans best practices employment, and they have been trained to understand, the veteran transition, the veteran, special issues for their veteran employees. So this recommendation would be to create a workforce program that is similar to the V3 program for people with disabilities, to increase their employment opportunities and promote economic development by training and certifying organizations in disability workforce best practices. As written, I did not confine this to just long-term care facilities, though I certainly can rewrite it so that it is long-term care facilities only specific. Any thoughts? Keep it broad, narrow it, give you both a broad and a narrow option? I'm not hearing anything. Is my audio working?
I think in general, broad options are best because it affords more leeway to the decision makers and the policy makers ultimately. So unless there's really a need to define things further, I think broad options serve people best. I know that there's a lot of inclination to impose details, but that may not be most helpful in the long run.
Right. And on this, getting to the idea of who would implement it, I know when we had talked, or not we had talked, but when we had heard from DBVI and DDHH that some of the programs for workforce development are with DARS and some of them are not. So because of that sort of hybrid, not hybrid, but that sort of split model, I should say, I think specifying which agency it should go to is probably not the best idea. Kind of getting back to Dr. Pratt's point about making it broad. That way DARS and DDHH and DBVI can work with policymakers on what would be the best home for this program if it were implemented. Okay. Continuing on with some of the things that we'd heard from Veteran Services, from Todd Barnes and Heather Legary, was some barriers to the MMAC program, the MMAC program. So one of them was requiring changes, this would be statutory changes, to the nursing home regulations to permit care by non-credentialed individuals who are in the MMAC program. Please stop me if you have questions as to what that would entail, or if I need to be more detailed about what we mean by anything in that sentence, other than spelling out what MMAC stands for, excuse me. Okay, not hearing anything. Mr. Barnes and Ms. Legary had also brought up that having civilian credentialing / licensing reciprocity was something that was needed so that state regulatory bodies recognize the civilian equivalency of certain military allied health specialties. Hello, did someone just? Okay. Continuing on that same front, civilian educational credits for statewide standardized recognition of military medical education and awarding of equivalent credit hours. And then just generally, awareness campaigns for the MMAC program and healthcare employment opportunities provided by that specific program. So, and to the question of who would do the awareness campaign, it's been my experience that typically that goes to the agent, that responsibility gets put on the agency that has the program. So for example, the COPN program at VDH, we have a mandate given to us to do an awareness campaign about that program that came to VDH, obviously, to implement. Just as an example. Okay. Getting to some more financial pieces, we had talked about a state income tax credit. This is all state taxes here, for CNAs, LPNs, and RNs who are working at licensed nursing homes and certified nursing facilities. And the reason I specified both is because some facilities are licensed but not certified, and then some facilities are certified but not licensed. It's a small number, but it's important to call them both out so we make sure that we're not inadvertently leaving folks out who are working at long-term care facilities. Not hearing anything about that. Okay, state income tax credit for private sector businesses for hiring individuals from, so any of the 10 target groups, I'm sorry.
Rebecca, this is Dana, students of Leading Age Virginia. I wanted to comment on the first bullet.
Yes.
I understand the issue about license, but I would suggest taking that out because we want to promote the workforce in all nursing homes, regardless of licensure, I would think. As to whether they were Medicare or Medicaid certified. So that would be my recommendation.
So if they're not a licensed nursing home,
I mean,
there are some facilities that aren't licensed, but if they're not licensed, then they do have, like, for those few that are not, they do have the certification piece. I don't know of any facility that's out there that's acting as a nursing home without having one or both.
Yeah, I'm
certification.
sorry. I think that I should have been clearer. I would take out certified nursing homes and just say all licensed nursing homes.
Okay. Hang on a second. Let me just make a note. Okay, I do have one question to pose to the group about this particular one. So we've been talking about nursing homes, and I think we all have a good idea of what a nursing home is, but we also have long-term care units in hospitals that are certified through Medicare and Medicaid for that long-term care portion of it. It's not, I mean, you have the hospital license, but then you have this long-term care unit. Do we want to include the long-term care units in hospitals as part of the potential state income tax credit?
This is Vivian. I would say yes.
All right, thank you. Anyone else thoughts on that matter? Okay, well then I will tweak that so certified nursing facilities are taken out and we include hospital long-term care units in that list. Okay. So these next two were, you may recall, there were federal programs that were, these are federal tax, there are existing federal tax credit programs, but the way that those existing federal tax credit programs are set up, the vast majority of nursing homes, for-profit nursing homes, would not qualify for them just because of the eligibility requirements on them. So an option would be to create a state version of them, but to modify the eligibility requirements so that nursing homes, the for-profit ones, could take advantage of those income tax credits. And the reason why I say the for-profit nursing homes is because if you're not for-profit, there is no income tax component for you. So the first one, there was the 10 target groups that face barriers to employment, just generally. So there's a tax credit for them. And if you'll give me a second, I will get a hold of what those 10 target groups are. 1 second. So those would be your veterans, your folks who are long-term temporary assistance for needy families recipients, short-term TANF recipients, food stamp recipients, what's considered a designated community resident, a vocational rehabilitation referral, an ex-felon, supplemental security income recipients, summer youth employees, and qualified long-term unemployment recipients. Those are the 10 target groups in the federal version of that program. I know that there is a criminal background check component to state law about nursing homes. So depending on what the ex-felon is an ex-felon of, they may not be able to be employed because of the criminal background check. But other than that, I just wanted to point that out. So those are the target groups from the federal piece. We could, of course, draw it more narrowly or more broadly, or we could just stick with the 10 groups that the feds use. Okay. And then there is again, this would be the state version of the federal state income tax credit for disabled access for-profit nursing homes. So if a for-profit facility expends money to make accommodations for a disabled an employee with disabilities, they can offset the expenditures that they, the money they put out for that accommodation against whatever their income tax is. So that's what that one is for. And then the last one here is, since our not-for-profits do not have an income tax, the sort of inverse for them is a tax relief program for them that would allow them to offset part of their payroll tax for expenditures aimed at providing access to employees with disabilities. I don't think it should be dropped to zero. That's why I say offset part, but of course I welcome any thoughts on that. But I didn't explicitly call out how much they could offset, but I don't think having it drop to zero is the best idea, considering what our payroll taxes go to pay for. Okay, not hearing anything? Okay, so I know we have talked about studies on culture change and leadership in nursing homes, and I will write up recommendations for that. I know we talked about, 1 second. Yes, I think that was the only additional one that we had put in for this slate. And like I said, these were all recommendations from our prior work group meetings. What other recommendations, other than the ones you've just seen, that I will make the changes we've discussed to, and the study one that we talked about for culture change and leadership in nursing homes. What other recommendations do you all want to see as options for you to vote on? Please tell me.
This is Sam Cookage. For future work groups, are we going to ever say anything about maybe establishing ratios as a way to help the workforce in the future?
So when I put the slides together, like I said, this is based on our prior work group meeting, so I didn't include today's topic in there. That's why it's not in here. But hang on a second. Apologies, I'm flipping back through. This, you all hopefully recall from earlier, this was some of the opportunities for recommendations that Mr. Rivenbark had put forward. So I don't have a problem porting all 7 of these into the recommendation list.
Okay, is that one talk about establishing ratios of instead of how it's worded right now, where it's sufficient that we can actually dictate, but say establish ratios with specifics in mind?
So hang on a second, I gotta zoom in a little bit. So the last bullet point on this particular slide says, following intentional workforce development initiatives, explore statutory changes for minimum staffing ratios for licensed nursing homes. So that recommendation?
I'm sorry, you need to say that again. I can barely read that here.
Yeah, let me see if I can zoom in a little bit. I don't know if this is zooming in for everyone else, is it?
No.
Are you seeing any changes to the PowerPoint slide?
No, it's not zooming in.
Okay. I guess it's just zooming in on my view. So I'll read it again, but slower. I apologize. So it says, following intentional workforce development initiatives, explore statutory changes for minimum staffing ratios for licensed nursing homes.
And what does that mean?
Can I, this is Joni Latimer with the Ombudsman Program. I just wondered if I could ask a logistical question at this point.
Sure.
I think we're sort of living out part of what many of our consumers and advocates perhaps had worries about in our process, which is that we are kind of getting down to the wire, and we fully appreciate the pressure of getting these recommendations together. And sort of on this day, we're kind of seeing for the first time these potential presentation points that drive possibly recommendations specifically about staffing. I feel like that is so huge and so important to so many on this call that I want us to be able to be thoughtful about what that recommendation looks like, how it takes form. So I'm just wondering, is this something we could buy just a bit of thinking time and discussion time around before we have to come up with the verbiage that gets us where we need to go there?
Yes. So what we're doing today is just trying to dial in and focus what the potential recommendations are. So we're not taking a vote today, just to be completely clear. We're not taking a vote on any of these today. As I mentioned earlier, Dr. Pratt and I do ask that each stakeholder group designate one person to be their voter and to get that information to us by September 8th so that we have enough time to, follow up with anyone who, may miss the deadline or anything like that. But I can just tell you now, it's 3:40. The next work group meeting, I'm going to come back to you all having reworked some of the recommendations that we've talked about based on the feedback that I've gotten from you guys. And we will continue to refine them further. As I had pointed out, everything that I had on the later slides were stuff we had talked about at the prior work group meetings, which obviously doesn't include the staffing piece of it because Brendan Rivenbark just talked about it today. So I'd like to take the remaining 20 minutes that we have to at least start diving into that piece of it. But I understand that conversation is going to continue to the next work group meeting. like I said, I'm not expecting anyone to vote today, tomorrow. My hope is that we can have a vote by late September, early October. And the reason I say that is because we have to write a report. And so with everything else that the agency has going on, Dr. Pratt and I will need time to do that. And we want to, of course, come back to the work group and present them with the draft. So it's not, oh, we voted on something and then we never saw it again until it got published out on the reports to the General Assembly website. So that is what we are hoping to get done. So like I said, the next work group meeting, we're still going to be talking about what's going on the list of here's all the potential recommendations, which includes the staffing piece of it. But yeah, that's I wasn't hoping to get a vote today on any.
Gotcha. Right.
Yeah.
I wanted to sort of get a better understanding of the sense of the workspace left to us, because I know that many of those who were very active in pursuit of the legislation that sort of sparked this whole process, the central core issue was about that, getting adequate staff in place. And I think we've done good work around other areas, but probably haven't hit that nail on the head.
Right. Yes. Like I said, I'd like to have the yes, no, abstain, whichever, support, oppose, abstain for the recommendations by end of September, beginning of October, so that Dr. Pratt and I have time to write that and then get you all the draft. But like I said, it's not today. I would not spring that on you.
What did you say we're supposed to do by the September 8th?
Oh, to get us the names of the person, the name and the email address of the person that you want to have be the voter for your organization. And the reason I put it at the reason I put it at September 8th is just we all have a lot of stuff going on, and I understand like things fall through the cracks. So if we set the deadline at the 8th, if we have to circle back with people, that gives us time to try and work with stakeholders to get us the information that we need so that we can vote it on time at the end of September, beginning of October. That's why we just asked for it, so we can get that squared away. And of course, if you need to change the person after you tell us, that's fine. We just want to, it's a relatively straightforward ask, so we just wanted to get that squared away sooner rather than later.
Yeah, that's not a problem. I thought we were supposed to vote by then, and I thought, no.
Yeah. No. No, that's just so that we have the information on hand and can start on the back end, building the form that we'll distribute to you all so that you have it to vote on.
So getting back to this bottom bullet that I can't read, could you tell me what that means?
So I, of course, defer to Brendan, if he's still on the call, as to what exactly he meant. But my understanding from the presentation he gave today was that for the states that have enacted staffing ratios, they had the workforce available to achieve what the mandated staffing ratios were, to achieve or to exceed it, because I feel fairly confident in saying all of them are minimum staffing ratios. None of them are maximums. And to Brendan's point, I think he was trying to explain that since we have a workforce shortage, mandating ratios right out of the gate is setting up facilities for failure, because the qualified workforce is not there in the numbers that is needed for all facilities to meet those numbers. And that as we keep talking about, it is a multifaceted, multi-layered problem that we are trying to hack at, and that ratios right out of the gate would not be the best way to move forward if we don't have the workforce there to be hired, the qualified workforce there to be hired, which is what I think he is getting at by saying following intentional workforce development initiatives.
But let me ask you
changes.
Yeah, let me ask you something about that. I understand what you're saying, but what's to prevent us from having a recommendation that you only let in so many? I mean, why overload the nursing homes if you can't care for them? Because that's no better. So why would you take in more people than you can care for unless it's greed?
So are you saying, just make sure I understand, what you're saying. Are you saying that instead of it being, let's say, a staffing ratio, it's you facility can't exceed this?
Well, they kind of go hand in hand. They kind of go hand in hand because, for example, let's use a school example. You can only have 25 students in the classroom. Otherwise, I mean, and the classroom closes at 25. There's no more. So if you're going to have a nursing home and you can't care for them with a specific ratio, then you can't come to this nursing home. It's closed. I mean, why would you set people up for failure or death when if you just establish the fact that this is our quota, we only have this many people because we can only take care of this many people properly?
Well, I will say that when it comes to the number of people who are permitted into the nursing home, and I am going to, is Scott Johnson still on the call? Yes. Okay. I'm probably going to have to ask Scott to kind of help me flesh out this particular point. But when it comes to the amount of people that are permitted in a nursing home, you know, when it comes to nursing home beds, we have this Certificate of Public Need program. So for a facility to have the number of beds that they have to have demonstrated a need for nursing home beds in that particular area of the state. And provided they can, you know, they make that case, they have the data to back it up. I mean, there's this whole application process before you even begin to get into licensure. COPN has to come first. So the facilities that are out there now that have the beds that they have the beds that they have because there is a need for the beds, that there is a need for the care. And the problem we're running into with this clinical workforce shortage is that we have the people who need beds. We have the beds to put them in, but we need more staff to staff the beds that we have authorized.
Yes, but if you can't take care of them because you don't have the staff, then don't take the residents because they're not going to get the care.
Which I guess is ask the question, what happens to them? The ones that need the care, that need the beds.
Well, right now what's happening is people who are going out into these facilities who think they're going to be cared for are falling or dying from something as simple as a UTI because they're not cared for. So why would you want that?
I don't think
Rebecca, this is Scott. I couldn't get off of mute when you had called me earlier. I apologize. But the way you articulated it was, you said it well, and I would just go back to what Melissa said earlier. You know, generalities get you in trouble, but yes, obviously you have a certain number of beds you're licensed for, and obviously you have patients, and obviously you are supposed to have sufficient staff to handle the acuity. But when staff numbers change, you know, that's when you get into your challenges. So I think the way you described it was accurate.
Well, it may be accurate, sir, and I appreciate that. However, if your mother or father or somebody was dying in there because there wasn't enough staff, how would you feel? It does come down to a personal thing. Those are real people. You can't just say, oh, well, they're a bunch of old people. Yeah, old people die all the time. The point is that's your mother, your father. You don't even have to be old to be in these nursing homes. But if they can't care for you, you know, one of the people in Dignity, a father couldn't go to the bathroom. Nobody would help him. He got himself up, went to the bathroom, came back. Nurse yelled at him, startled him. Guess what? He died. He died because there was no one to help him go to the bathroom. It wasn't difficult, but that's exactly what happened. What do you tell those people?
Well, as we have all said before, going back because it seems like we're repeating ourselves at every one of these meetings, we all want to address the workforce issue. We all want to make sure we've got sufficient staff, and that's a common goal. So we keep reverting back to these examples, you know, that I don't know how many times we can say that's a common goal. That's what this work group is for. It's not one silver bullet that's going to solve everything. NVIDIA has come up with many different options, and it's not going to get solved overnight. So we need to start. We need to get going, put these in place, refine them, figure out if we can improve on them. I mean, it's a common goal we share, and it seems like at each one of these meetings we keep reverting back to an us versus them, when I think if we focus more on positive solutions and working as a team, then this work group will continue in the right direction.
I think the problem, sir, is that this bill has come up for 16 years, and we keep hammering this time and time again. And it seems like profits are being made over personal care, and that is the issue. And people do die.
This is Dana Parsons with Leading Age Virginia. Thank you, Scott, for what you said. I just want to echo that and just remind the group that this generalization that this is happening in all nursing homes has got to stop. There are nursing homes out there that provide wonderful care, and they're in an extreme situation right now with COVID, and they are doing remarkable things. And I think that we've got to get away from, as Scott said, this issue of us versus them. We all do have a common goal here. And I just want to reiterate how many wonderful nursing homes there are out there that are providing outstanding care. Thank you.
Yes, I would like to make a comment. Someone was saying that they don't think it's appropriate to mandate staffing relations. Well, there's been a lot of studies done that how important that is. I know that Consumer Voice with some PhDs did some studies, and they recommended that the staffing level should be anywhere from 5 to 7 CNAs per residence, and there's quite a bit of studies on that, and it's very easy to pull up. Also, what is wrong with mandating them? There have been a lot of different things that have been waived during COVID-19. The staffing ratios could be also waived, but it could be put in there so that when the staffing catches up, then it could be enacted instead of putting it off for another 15 or 20 years.
So this is Rebecca again. To your point about the waivers, I do. So in BDH terms, those are called variances. In case you want to look through our regulations, but when it comes to waivers or variances, as we call them, the board has specific regulations about this. As a general matter, blanket waivers aren't really a thing that is done. This is a special time that we find ourselves in, of course, with COVID-19, which is why we have Executive Order 51 that lets us, I shouldn't say us, that has a mechanism in place, but only for these emergency situations. Typically, variances, waivers, whatever you want to call them, are specific to the facility. And I mean, it doesn't make a ton of sense to have a mandate that then there is an expectation that we set it aside for every licensed facility, which means 200 and some, nearly 300 separate specific waivers that have to be issued, because we know they can't meet it now, but they could meet it 10 years from now. That's a kind of a weird outcome to come with that. We want you to meet this, but we don't want you to meet it. Meet it when you can, however many years down the road. And it gets back to the idea that, I mean, increasing the clinical workforce is the goal of this work group, is to come up with recommendations to increase the clinical workforce. That is the goal of this work group. And when it comes to the staffing ratio, maybe we need to reframe the conversation. So instead of it being, here's what you have to meet, and if you don't meet it, fire and fury rain down upon you. That's a very stick approach to it. Maybe we frame it as more of a carrot approach, where if you facilities can achieve this staffing ratio, maybe we make it tiered. So tier 1, tier 2, tier 3, whatever the hours, whatever the ratio happens to be, you get an increase in your Medicaid dollars, but only if you achieve the increased staffing ratios. That incentivizes them to, obviously, because I mean, we've talked about, Medicaid funding is an issue. So if I get more Medicaid dollars by increasing my staffing, then that might be a way of going about it.
I think that's a great idea. And The other thing I was going to say is if, you know, I keep saying 6-to-1. That's, when I went to the last nursing home my mother-in-law was in was the best. And I said, why? Why does everything work here? Why am I not upset? And she said, well, because we have staffing ratios of 6-to-1. That's where I came up with that because it worked and it kept my mother-in-law alive and she was cared for. You know, I agree with you. I think it'd be great if we, even if we establish 10-to-1, just have something because right now it's a free-for-all. It's, guess what? You come in, you get 36 to 40 patients. Why can't we? I think the tiered approach would be great. It'd be something.
Right, and the point I'm trying to make with all this is that I understand the frustration. I certainly have had family members in nursing homes, and we've moved from one nursing home to another. I definitely understand that concern and that frustration, but I think a penalty approach is not the way to go. I think, as a general rule, in pretty much every area of life, that people that you usually get better results by sweetening or by making it a carrot approach versus a stick approach. No one likes to get hit.
Let me interrupt. I didn't say a stick approach.
Yeah.
If you listen, I hate that if you're talking about me. I didn't say that.
No, and I wasn't trying to imply that anyone. Right. It's just in my experience, the staffing ratio bills that I've seen come through in past legislative sessions, the way that they are phrased is, Board of Health shall establish regulations that mandate the following minimum staffing hours ratios, however it's phrased. But it's like, here's your mandated minimum, which the corollary to that is, well, if you don't hit your mandated minimum, there will be consequences, and they're not positive ones. They'd be negative because you didn't hit the minimums. And that's what I kind of frame as a stick approach, is that here's your minimums. If you don't hit it, then the consequences to follow, and not positive ones. So that's why I was saying, like, maybe we reframe the conversation instead of it being hit it or consequences, negative ones. Instead, it's here's some staffing ratios tiered, however we want to set it up. And if you hit them, you get more Medicaid dollars.
But if the Medicaid dollars goes to the CNAs and additional staffing, and it's built into the law where it doesn't go to those that are making money off the residents.
Well, and in conjunction with that, I know CNAs, and Erin is one of them, who has told me, Sam, if I had more help, maybe I wouldn't need more money. I just can't do it. She's broken. She feels bad for the residents. And I'm not saying they don't deserve a pay raise. They do. But I am saying she can't do her job properly. So to me, if they had more CNAs, that would be a reward for the staff.
Yes. So to Mr. DeCure's point about making sure it goes to the CNAs, you'd raised that point on one of the other recommendations, those about increasing Medicaid funding. And the same thing with that, I'll talk to DMAS to figure out the best way to phrase that so it is money. It's increased funding for the direct costs of nursing care services, aka the staffing costs. So I will talk to them about how that actually should be phrased so that it does go to that particular purpose.
Well, I appreciate that very much. That will be great. Thank you.
Right. And then I see we're up on our time here. So what I will do, like I said, I got to circle back with DMAS. I'm going to talk with Dr. Pratt about refining the financial incentives piece for that child care transportation piece. There's several other things on the to-do list to refine these. And then I will work on some draft recommendations about a sort of a carrot approach to staffing, and I will present several options. And again, if we want to vote on more than one option, we certainly can do so. But I will work with Dr. Pratt to come up with several options and sort of a carrot approach to see which, if any, are good for the group to put on the ballot for the staffing piece. Okay. So again, I thank everyone for your time. We have gone right up to 4 o'clock as we usually do. So thank you, everyone. I hope everyone has a wonderful rest of the week and a wonderful Labor Day coming up as well. So everyone stay safe and have a good one.